All right. So Medicare supplements, what we're looking at is that original path, right? So one of the things that I encourage you guys to do, and look, I know we're all really busy, right? If we've got families, we've got work, we've got different lines of business, we've got the holidays, we've got life happening. I get it. Um, but one of the things that I encourage you to do is look up the um, Medicare and You book. You can find it on Google as a PDF. It's like 140 pages, give or take, right? Um, and see that this information is in there, right? Now I've consolidated a lot of it so that it makes sense, but all of this is in there. The costs for Medicare supplements will not be, but one thing that is handy about the Medicare and You book is it does break down what is covered under um, the different plan types, right? So one of the things I'm going to do is just going to Google Medicare supplement plan types side by side. Looks good. No, that's a big advertisement. Let's not go there. PDF. If you're ever looking for forms, I highly recommend just putting PDF. Can you guys see me scrolling, or are you still back on the other page? Okay. So here I'm on Medicare.gov, choosing a Medigap policy. Hey, that's right from the source. Wonderful. So actually, let me scroll up here. Okay. So this right here is what happens with a Medicare supplement. This is what their monthly payment covers. And you can see there's different plan letters, right? So one of the things that I do when I sit face to face with a client, and they have a med sup, or really with any client, I'm going to ask them to show me their cards. And I'm going to look to see on their Medicare supplement what plan letter they have. So then I can go back and I can look at this chart and say, okay, what kind of coverage do they actually have? What are they paying for? If they have a plan A, they have no coverage for their skilled nursing. They have to pay their Part A deductible. They have to pay their Part B deductible. They have to pay all the excess charges for Part B. So in my mind, I look at it like, why are they paying for a Medicare supplement? Because by the time you've paid the Medicare deductible, the Part A deductible, and the excess charges, you probably would have already hit a maximum out of pocket for a Medicare Advantage plan. And if they were healthy, they wouldn't have had to spend that anyway. So then I go through Part B and I kind of think close to the same thing, right? Now, Plan C and Plan F are special plans. Those are only eligible for people that had coverage through Medicare prior to 2020. So if they were eligible for Medicare for 2019 or before that, they can still get into a Plan C or a Plan F. Now, these are what we call the Cadillac plans. Those are the ones that cover everything. Those are the ones that I'm kind of referencing when I talk about Medicare supplements. And really, to be honest with you, there's only 4 plans that I sell. C, F, for those that are eligible, or G or N that are eligible. And why? because they're the ones that cover 100%, right? Um, you'll find that plans like K and L, they have a maximum out-of-pocket limit, but they also have a monthly premium. They also only cover half or three-quarters of what is actually done, right? So when I look at a chart like this, in my mind, I think to myself, my client is either not healthy enough to be on a Medicare Advantage plan. They're not manageable right now, and they should be on something that covers 100% of everything because their bills are going to reach an astronomical number, right? And that's where a C, an F, a G, or an N will come in place because really, when it comes to Part A and Part B, it covers 100%. Otherwise, if I do any of the other plans, I'm really kind of hurting them because I'm still leaving them with a lot of gap. And then they're paying a monthly coverage on top of that. So when I talk about Medicare supplements, and let's go back to page 1 for a second. Oops. That $200 a month, that should be a ballpark for either a G, an N, a C, or an F. It should be fairly close. Now, some of the northern states like Jersey, New York, that probably needs to be. Um, Gabe, did you just kick me off? All right. Can you guys hear me? Thumbs up. You guys can see the page 1 up there? Okay. Gabe just signed on, so we share the same login. So when I look at this, I look at that $200 a month. And like I said, the northern states, you might need to adjust this number because those are higher premiums, right? And so what might be a good idea is when you have some free time, go into your Sunfire, and instead of going into MAPD, take a zip code and play with the supplements for a minute. But keep in mind, you don't have to look at all of them. You're really only looking at G and N for people who are aging in, and you're looking at for C and F for people who have had it prior to 2020, right? And those numbers are meant to be easy so that we could do easy calculations. But you might have somebody like Adam, I think you say on your text there in the chat, you've got people paying $400 or more for a supplement. That's one person, correct? So 400 times 12, that's almost $5,000 a year. Now, if you bounce that off of what the maximum out of pocket, and Adam, you'll have to probably help me with this. What are your maximum out of pockets for most of the plans up in your area?
For Med Advantage,
Yeah, for like HMO, PPO.
like 5,300, like 5 grand to 5,500 is average.
Right. So you can kind of see the idea there. Like, if I'm healthy, why would I pay the same amount that my maximum out of pocket would take care of? Right? Which really drives down into page 3 when we start talking about the long-term effects, right? If you have a healthy year and you only go to the doctor 5 or 6 times for the whole year, man, I've saved myself 4 grand, right? But if I have a lot going on, and you can see, I don't know what hospitalization looks like for you up there, Adam, but I would assume it's probably two, three, $400 a day, probably a maximum of somewhere around 2,000 or 2,500. Is that about right?
Yeah, I'd say so.
Okay. So if you have somebody who's high risk and they have the they have enough risk factors where they may go into the hospital several times a year. 2,500 plus 2,500 plus 2,500 can get kind of high, but then you still have that safety net of that 5,300, right? So I look at it this way. Um, People who have to go to specialty clinics, people that do a lot of traveling. Um, for example, if you have a member that lives part-time in Miami and part-time in Puerto Rico, that might be a great candidate for a Medicare supplement because Puerto Rico is a territory of the United States that accepts Medicare, but the Medicare Advantage plans do not cross over. Medicare Supplement does. So it's little things like that that make the supplement make sense. And there are definitely times where a Medicare supplement makes sense. But again, when we go and look at what the coverage is, what you're trying to do is you're trying to figure out for the client that number, and 200 might be low. In Adam's case, it's half of what it should be, right? So you might need to adjust that number based in your area to truly reflect um, what the cost is and to give them a true comparison of what they're looking at. But I highly suggest only really referencing C, F, G, and N because otherwise you're leaving gaps and that's going to hurt the client in the long run. You might save them $30 a month, but you might cost them $3,000. Does that make sense? So we don't want to do that either, right? So my interpretation of page one is either I have somebody who I know who is going to basically max out what a Medicare Advantage would do, and I want to save them some money if I can and give them a lot of freedom to be able to go wherever they need to go. So, like, for example, a cancer victim would be probably a good candidate. Not always, but sometimes if I have to go to um, Shands or if I need to go to one of the really, really top-notch cancer institutes or something like that, they might not take Medicare Advantage. And so that might be somewhere where a MedSup is going to be the right choice. Okay. And then also, when we look at the MedSups, it's important for me to point this out. You see this Part B excess charge right here? You see that G covers it and N does not. You'll find the difference in cost between those two plans is probably maybe $5 a month different. It's not going to be that much different. So if you're going to put them on a MedSup and they have gained their coverage after 2020 or 2020 going forward, just go ahead and say G is going to be the right plan. We're going to find the company that offers the lowest cost for G, but G is going to be the right plan. Now, I could put you on an N, and N's not a bad plan. But if you ever have to go to one of those specialty hospitals, that excess charge is 15% above what they would charge Medicare. That could be several $1,000s. So for $4 or $5 a month, we might as well put you on the Cadillac, right? Same thing when it comes to the people prior to 2019. If you see a Medicare card that's before 2019 or 2019 or before, I always offer Plan F instead of Plan C. And I do that because of the excess charge. And the price difference is so small that it just makes sense to do it that way. Okay. Now, regardless of what you do here, sorry, Gabriel, he's been in my waiting room. Let me stop sharing here so I can see who else needs to get in.
Carl, are these are the Medigap plans? That's not something that they have to like get underwritten for, is it?
Well, so here's how Medicare supplements work. Okay. There's a 7-month window for Medicare supplements to be written. Okay. You got 3 months prior, the month of, and 3 months after they are eligible for Medicare to be able to sign up for these Medicare supplements as a guaranteed issue. So they could have everything in the world wrong with them, and they can still sign up for these plans in that 7-month window. Outside of that, there are some stipulations. For example, if they join a Medicare Advantage plan, um, and in the first year of that, they decide, I want to go to MedSup, they could still qualify for guaranteed issue. If they went from MedSup when they first were guaranteed issue, went to Medicare Advantage and said, oh, this is not working for me, they can still go back guaranteed issue in a certain time frame. Okay, so there are some guaranteed issue time frames. However, in general, um, Medicare supplements are life products. And so, yes, they are underwritten. And really, underwritten means that either you're going to get rated higher because you have something going on, or you're going to get denied coverage, right? So I should have thought to pull up an application for a Medicare supplement, but there's, I think, 9 sections of a Medicare supplement application, right? And each of those sections has disqualifiers or raters inside of those sections. So just like a life policy, are you a smoker? Yes. Well, guess what? Your rate's 3 times higher, right? Um, things like that are inside of those applications. But when you're guaranteed issue, the only thing that might change your rate is smoking. You could have had a heart attack the day before you signed up for this thing, and they still have to take you because it's guaranteed issue, right? So Medicare supplements are going to be the favorite for people, and I'll just break this down from my experience. People who do not want to mess with copays, they don't want to, and really the copays is a big thing. They just want one card that does it all, right? Those are your Medicare supplement people. And I will tell you from my experience, a lot of people who are affluent or have a higher income may want Medicare supplements, and that's fine, right? If they're happy paying that premium, even though they're fairly healthy, um, Medicare supplements are the most free product available. And I mean that by not free as in cost, but free as in you can go wherever you want to go as long as they take Medicare. And the reason is the way that it's billed. So Medicare is billed first. So they know they're getting their Medicare payment, and then the supplement comes behind and fills the gap. So whatever plan you take, which so for example, if you took a plan K, you're getting 50% of what is left over, but they have to pay the other 50%. But if you put them on a C, G, F, or N, then they don't have to pay anything. They just show their card and they're done. And a lot of people who have earned higher incomes will appreciate the fact that all they have to do is show a card, right? So that's one demographic that may prefer Medicare supplements. However, we still do pages 1 through 4 with them, right? And we let them choose. And this is why it's important and why I wanted to do this training specifically to allow us to be unbiased. Our goal is not to push Medicare Advantage. Our goal is not to push Medicare supplements. Our goal is to make our clients happy with their decision, right? So if they prefer just to go to the doctor and hand them a card, then we can do that for them, right? And we have the option to be able to look up multiple companies to see which one offers the best rate. So that's the benefit of being a broker. And so that's one demographic. Another demographic is, again, like I have mentioned in my previous trainings, the people that we would consider train wrecks, right? And again, I'll explain what I mean by that. A train wreck happens, it's an event, and then there's cleanup, and then the train opens back up, right? And so when I talk about a train wreck as a client, I'm talking about somebody who has something pretty catastrophic going on or is about to have something catastrophic going on, and they know that it's coming. So they might want to go into a Medicare supplement mostly for the freedom to be able to go to wherever doctor they want to, because as we can see, when we go through page 2 and page 3, the numbers are probably going to favor Medicare Advantage, but they may need to go to a specialty clinic to take care of their specific issue, right? They just might need that kind of coverage. So there are definitely times where Medicare Advantage makes the most sense, even when the numbers tell you different. But this is, and if you guys want, you saw, I just Google Medicare supplement plans and go to the Medicare.gov version of it so you can see what they cover. But you can also go inside of your Sunfire and take a look at these and see what the costs look like for your zip code, right? And I would highly encourage you to do that, because these numbers that you'll find inside of Sunfire are going to be, I'm going to try to move this. There we go. Those numbers are going to be way more accurate than what I have right here. This is just an example. So this example doesn't work well in Michigan because it's $400 a month. Drug coverage, that's just an average, right? There's plans in Florida that are as low as $8 a month. There's plans that are high as $150 a month. So that's just kind of an average to get them to understand the concept of Medicare supplements, right? You might have to go in a little bit deeper and in your area, if you find that your Medicare supplements are much higher or much lower, which I highly doubt, but if you find that those numbers are drastically different, you're more than welcome to go in here and change that, right? And make it more adaptable to your area that you're working in. So page 1 is really just an example of how things work. It's a high level overview. And I use those numbers because they're average numbers, but they do easy math at the end of the day. I can do 3,000 times whatever years, and it's just that times 3, right? Instead of having to worry about 2,560 or, $4,300 or whatever, right? So this is an example, and that's why I use that to make it easy for them to understand. But I did want to convey with you guys that you should look at the supplements in your area and see what the costs look like. You'll probably find that my numbers, when you average them out between the Medicare supplement and the Part D, are probably pretty close, or they might even be lower than where you're at in your area. So what are disqualifiers for Medicare supplements? Well, we talked about guaranteed issue, right? You've got that 7-month window that no matter what, you can sign up for a Medicare supplement. If you find somebody that's got a terminal illness, you probably want to put them on a med sup. Probably it's just going to make the most sense, right? Unless they're low income, and they can't afford it, right? But if they have the money to pay for it and they know that they're going to have, a bunch of imaging, a bunch of hospitalization, chemotherapy, um, uh, all kinds of stuff happening. And they're going to hit their maximum out of pocket no matter what with Medicare Advantage. Instead of making them go through Medicare Advantage with referrals, or having to get approval for an MRI or a CT scan or something, and delaying maybe some of their health care, just go ahead and put them on a Medicare supplement. Once they get to a healthier stage, and my example probably is one of the best ones that I can think of. I've got a friend of mine who, and I say friend, client, right? He started out as a client. He's a friend now. We've been friends for 8 years. When I first met him, we put him on a Medicare supplement because he just found out that he had stage 4 pancreatic cancer. That first year was pretty rough. And it was a good thing that we did that because the maximum out of pocket for the PPO plan that I would have had to put him on was about 5,600, and he maxed out at 3,000 with a med sub. So we saved him money. But the next year, we got him to a manageable space. And so we started moving him over to a PPO. And ever since then, he's been on a PPO. Now we've had to shift him from one company to another, one time, in that 8 years. But you'll find that med subs they definitely have their place in time. But sometimes med subs are not the full answer. They don't continue to be the right answer. So you'll have a lot of people, and I've had this question asked to me a lot when I talk to people directly that have called me. They'll say, hey, I've got this lady, she's got Plan F. She doesn't pay anything. And I say, well, that's not really true. She's prepaid for her health care, right? So page 2 is extremely important. And for those of you that don't know what I'm talking about, go back and look at my references inside of Legacy Benefit Alliance, right? But page 2 breaks down what their annual cost would be on a Medicare supplement versus either an HMO or a PPO, right? And so just because a Medicare supplement was the best policy for them when they first joined doesn't mean that it continues to be the right policy. They might have just gotten used to it. They may be used to just handing that card and not having to deal with it. But keep in mind your demographic as well, right? If they're pretty affluent, then maybe what we can do is we can take care of their drug coverage. Because what I find with Medicare supplements, when you have standalone drug coverage, is those people most of the time are going to change their drug plan every year or every 2 years, right? Because they're trying to save money. And realistically, if they'll listen to you, if they'll listen to pages 1 through 4, they'll realize that $5 or $6 a month that they're paying, or that extra $5 copay that they're going to pay for their drug, actually would look minimal compared to the $1,500 that they would save with Medicare Advantage. So again, I'm not saying that we lean toward Medicare Advantage, but the numbers don't lie, right? When we go through pages 1, 2, 3, and 4, it helps them to see what they would pay, in their specific circumstance. But there are times where Medicare supplements do make a lot of sense. So, Let me see. There's a couple of questions here. Let me address. Couple explaining that as well. They're very unhappy not only with coverage but also was. They had been seeing their most additional income. Awesome. It's just, and said their set was never paid out because they don't pay anything. Okay, so Connie, let me address what you said in your second comment there about MedSup's not paying. So you will constantly hear me refer to a MedSup as a life policy, right? You guys that sell life insurance realize that there are ratings, right, for life companies, right? There's A or double A, B, good, better, best, garbage, right? Based on how they pay out. And so med subs are the same way. They're going to have the same kind of rating that a traditional life insurance product will have. So keep that in mind. You might have somebody with, let's say, Americo, or I don't know, I don't want to give a name out, but Joe Schmo uh, MedSup insurance, right? And that rating is a B minus, right? Um, don't put them on that plan. Don't do it. Why? Because their bills are not going to get paid. The doctor's going to get mad. Doctors are going to say, look, either you change your insurance or you're going to have to self-pay, right? The difference from what Medicare doesn't pay. So just like a regular life insurance policy, you've got to be wary of the rating that they have. The big companies that we are contracted with now, which you should also have access to most of their Medicare supplements. For example, United Healthcare, you can sell their med subs. Humana, you can sell their med subs. If you want Aetna, just let us know. We can get you set up because it is a different contract. But Aetna has supplements. Cigna has med subs. You don't have to do anything different for that. You already have access to it. So there's a lot of companies that you already have access to that are the big companies that are A-rated companies that you can sell med subs for. Okay. The ones that we have not done anything with are probably the lower the companies, the B-rated companies are below. So that's where you want to be careful is you can shop. There's probably 100 different Medicare supplement companies out there, but they're not all good. And so if you're going to do your client right, and if you want to keep your clients for life, you want to make sure you put them in a good product. Okay. Okay, Ronnie, one of my prospects needs dialysis 3 times a week. Yeah, that person is probably going to hit their maximum out of pocket, right? So that's a good one where you have to look to see if the med sup and the maximum out of pocket for a PPO that has that dialysis place in network are going to be equal or not, right? And if they're equal, that person still may be a candidate for Medicare Advantage, right? Just because they're dialysis 3 times a week, which probably means they're ESRD, right? End stage renal disease. That actually used to be a disqualifier. 2 years ago, they said, no, we actually should let them choose Medicare Advantage too. So that person, if their maximum amount of pocket is going to be within a very small amount of what their med sup is, then they're still getting free drug coverage. right? They're still getting dental, vision, transportation, and all those other things that come with the Medicare Advantage plan. So just because they have dialysis 3 times a week does not necessarily disqualify them from being a good PPO candidate. But you have to look at it fairly with them, right? You want to make sure that you find a company where that dialysis center is in network, so they're not paying out of network cost, and look at what the in network maximum out of pocket is going to be and say, okay, this is where we're at, right? Um, MedSup, we know it's going to cost you this much for the year. Medicare Advantage, you're probably going to hit maximum out of pocket. But after this point, you don't pay anything for any of your stuff. So if they're the same, I might as well put you with this so that you have all the other benefits as well. Does that make sense? So just because they have certain things going on, the money factor is probably, in my opinion, the biggest fork in the road. It helps you decide what's best for your client. Now, when they even up like that, it really depends on their situation. If like in that situation, if it's just dialysis and their what is it, nephrologist that they have to go to, um, are both in network with a PPO, if the cost is going to be the same between maximum out of pocket and what their med sup plus drug coverage would be, put them in PPO because then they still get all the other benefits. They get the dental, the vision, they might get free money for food, and there was something about a gas card I was reading. I mean, there's a whole bunch of good benefits in Medicare Advantage plans, right? Um, and especially if you can get them something special like somebody who's in a situation like that, we know that they're paying a lot of out of pocket, right? If you find a PPO that has a buyback, now you're actually giving back some money to them. So, like if you can refund $150 a month back to that client into their Social Security check, and the cost is not going to be any different in the MedSup or the Medicare Advantage, well, now we've done a great thing. We've actually given them money back for the year that'll help them with bills and other things as well, right? And we know the drug coverage is going to be fairly similar no matter what we do anyway. So that's kind of how I look at that. But hopefully that kind of answers that question for you, Ronnie. Okay. So med subs are fairly easy to understand. I'm going to keep this up, but I'm going to open this up to see if there's any questions about med subs right now. Okay. No questions yet. Sorry. Connie, I see you have a question there. With the give back, don't they lose benefit amount somewhere else? Well, I will say this. Medicare Advantage is an insurance product. Let's not get it wrong, right? And there's an actuary that figures out how do we make this fair, right? So that we don't get jammed and the client wants to be on this product, right? So again, it'll be more of going through page 2 and really understanding if it makes sense, right? But I would say if a maximum, if so, in this case that Ronnie brought up with the dialysis 3 times a week, and you got to see a nephrologist for sure, primary care, um, probably is going to have something else going on. I would be uh, I think it would be fair to say that they were probably at least pre-diabetic at that point, um, or they have some other kind of issues. So they're either seeing a GI doctor, or they're seeing a podiatrist, or they're seeing somebody for diabetes or something else to go along with the dialysis, right? When kidneys fail, other things start failing too. So to be fair, if their Medicare supplement was going to be $4,000 for the year, and the maximum out of pocket is $4,300 for a PPO plan, that's just a conversation that you have with a client. Like, do you want to pay it every month up front? Do you want to have the extra benefits? And we understand that those extra benefits might end up costing you about $300, but we know everything after that is going to be paid for on the medical side, right? So that's kind of where you have those conversations. That's where, when I say train wreck, um, it used to be automatic, just put them on med sup. Right now, the med subs are starting to get so expensive that the maximum out of pockets are starting to drop low enough where you just have to have the conversation, right? And the conversation is, where are you getting your treatment from? Is it a specialty place? Do they accept the PPO? Um, and do you need the other benefits? I mean, somebody from dialysis, if they got 100 free rides a year, well, they might be a single person that has to take their little thing with them everywhere they go, right? And this is not just getting in a cab. This is like high quality ADA transportation that comes to pick them up, takes them to their appointment to get them there on time. They can drive them to the pharmacy to pick up medicine that may be needed, and then drive them home. So that's not included in a supplement. You know what I mean? That might be a benefit that they're like, shoot, that alone will save me $300 would be cheap compared to Ubering or trying to do this through a taxi or bothering my family. You see what I'm saying? So those are conversations that you have to have when it comes to when the Medicare supplement cost and the Medicare Advantage maximum out of pocket cost are very close. But usually there's a pretty big difference, and you'll see that. Like the maximum out of pocket for some PPOs is $10,000. Well, if I can put them on a plan N or G that's only $5,000 and they have this situation, well, then maybe it makes more sense to go ahead and put them on the Medicare supplement, right? So does that make sense to everybody? Is that pretty clear? Okay. All right, let's see here.
Hey, Carl, just a quick question here. I had a distraction when you were talking about the 7 month window of guaranteed issue. What was the trigger for that? Was that their birthday?
It's their eligibility for their Part A and Part B.
Oh, gotcha. Which is
Right.
usually the month of their birthday.
Usually, but if they have group coverage and they elect not to take their Part B immediately, then that will be from their Part B date. So, for example, if they decide to work an extra 5 years, then it will be effective 3 months prior to the end of their group coverage, all the way till 3 months after the group coverage has ended. Okay. Can you enroll a client to same carrier but different plan? Yes. Yeah. So if somebody has an N and you want to upgrade them to a G, you can do that very easily. You just submit the app up to the carrier. If they're already approved with the carrier, that's really just a switch, right? Because
This is
they've already
it's a Medicare Advantage plan. I just run a comparison. He's currently on a Humana plan, and I found a better one
a
that he
different
liked.
Humana plan.
Yeah.
Yeah.
So meeting them later, and I'm not sure if I could enroll him into that plan.
Absolutely.
Okay. Thank you.
Anytime that they move from the plan, and this is important, when we're going to step away from MedSup for just a quick second, we'll come back to it. Anytime that somebody is on a Medicare Advantage plan, you'll notice let's see, let me try to pull up Humana. Try to pull up a plan. This doesn't get me off the weird stuff. No, this is not where I want to be. You know what? Let me just do this. Okay. Can you guys see the Medicare.gov site that I'm on right now? Okay. So anytime that I go to change a plan, you're going to notice that every plan, sorry, this keeps blocking my stuff. So I've got to keep moving. All right. There is an H code associated with that plan. Anytime that that number changes for that client, they have gone into a new plan. And if you're the person that puts them into that new plan, you are now the new agent of record. Okay. All right.
Thank you. That's exactly what's going to happen. Thank you.
Perfect. Okay. Tammy, you're welcome. Okay. Oh, thank you, Ronnie. Okay, so while we're playing around with these, oh, I lost my MedSup chart. Any questions about MedSups? Because I feel like that's kind of been a sore spot that we've kind of looked over through open enrollment so far. So besides trying to fight MedSups, are there any questions about how they work, what the coverage kind of looks like, what people would not be a good fit for a MedSup or anything like that?
So did you say that we're all set to go with all the med stuff? Like we don't have to get appointed with them?
If you're appointed with United, part of your training was to get you set up with MedSups. That was like your, I forget what they call it. It's
Certifications or whatever.
yeah, there's a certain part of it though that's specific to the MedSups. And so yes, that training qualified you to sell United MedSups. Humana just lets you sell MedSups once you're appointed to sell your Medicare Advantage. If you're appointed with Aetna and you want to sell Aetna MedSups, because there are Aetna MedSups, you'll have to send a request in to get contracted because that is a separate contract. Cigna, you're automatically set up for MedSups. What else is a big one? Who else are you guys contracted with that I haven't covered? Blue Cross has MedSups. You should be automatic with those as well.
Automatic meaning when you get appointed for the Med Advantage, you're automatically appointed with med stuff, right? Okay.
So, and you can double check to see which carriers you are currently set up for just by going into your Sunfire, right? So if you go into your Sunfire and go into the MedSup portion, it'll show you all the carriers that you're allowed to sell the MedSups for. If there's a carrier that you want that you don't have in there right now, then just submit a ticket up to us and we'll make sure that we get it for you. Okay. Well, there's no other questions about how they work, because MedSups are pretty easy to understand, right? They're built to pay the whole bill, right? That's why we really only look at C, F, if they're eligible, and again, it has to be before 2020 on their Medicare card, or G or N if they have got onto Medicare after 2020. Okay, so what are some of the things that we hear from people who have been on Medicare supplements? Because there's a lot of people, a lot of companies right now that just sell Medicare supplements, and they try to braid Medicare Advantage, and they say, well, you can't do referrals. And matter of fact, somebody had sent something to me. It was a advertisement not approved by CMS that said, the difference between Medicare supplements and Medicare Advantage. Medicare supplements, you can go wherever you want. Medicare Advantage, you have to have referrals. Everything is prepaid. You've got copays for everything. It was, there was truth and lie all the way through it. So how do we overcome the people that are kind of stuck on Medicare supplements? And when you do page 2 with them, you're like, well, goodness, Mrs. Smith, when I look at this, it looks like there's like a $2,500 a year difference that could go back into your pocket. How do we fight that, right? How do we get the client to understand the difference, right? So on page 1, it's very important to help them understand what the differences are, right? And so I've told some of the people that have talked to me directly, there's a lot that has gone into this page, right? Not just information, but psychologically, right? When we look at Medicare supplements, we want them to understand the purpose of a Medicare supplement is to pay every dollar that they would spend, except for the ones that get G and N. They have to pay that $226 for the deductible, but everything else is 100% covered. But they're paying all of that money up front, no matter what their health looks like, right? So basically what you're doing is you're saying, here you go, here's my wallet. I've given you my whole wallet for the year, and there's no way I can get that money back. But when we come to Medicare Advantage, we have 2 different specific products that are there. There are HMOs, and those are built to be preventative products. The people that will enjoy those are people who want to save a lot of money, that have doctors that are in their network already, or are willing to change their doctor into a doctor that's in network. And they don't mind waiting for a referral. Now, people who don't like that system will look at a PPO that works very similar to a supplement, because it gives you the freedom to go to doctors that are in network or out of network. So in that instance, or that situation, it works like a supplement. But it also allows you, if you are not if you don't have a lot of usage, to save money throughout the year. So that's where page 2 and talking about those 2, the difference between an HMO and a PPO, is very important, right? An HMO is locked up in a network. A PPO does have a network, but you can jump out of that network anytime you want to. You're just going to pay a little bit more for that service. But if your services are not equaling the cost of a Medicare supplement, it might be to your advantage to go with a Medicare supplement PPO. And most people that I take from a Medicare supplement to Medicare Advantage, I will put them on a PPO, not an HMO, just because they are used to that freedom. They don't have to wait for referrals. They don't have to make sure that their doctors are necessarily in network. So if I'm going to take somebody from a Medicare supplement to Medicare Advantage, I'm going to recommend a PPO, and I'm going to explain to them why I'm going to do that. Because they're going to look at the HMO cost and say, well, darn, Carl, why would I not go to the HMO? Well, because you're not used to that. You're not used to waiting for a referral, which may take 3 or 4 weeks. You're not used to being able to call your specialist up and just book an appointment. But a PPO will allow you to do that. And so why don't we put you in a PPO? It's still going to save you a ton of money, but it's going to give you the freedom that you're used to with a Medicare supplement. And they'll say, well, that makes a lot of sense, right? So when I'm going through my pages 1 through 4, and I have somebody who has a Medicare supplement, it's very important to highlight the freedom that a PPO allows the client to have, so that they understand that it's not very different than their Medicare supplement. The only thing that's different is, instead of cutting a check for $200 or $300 or $400 a month, they're going to pay when they actually have a service done. But that's all they're going to pay. Okay. Any other questions so far? Daniel's got a question. Not meds up, but for Part B. Client age 70, very healthy, has Part A for a long time, but no B. Oh my gosh. Does not work. Now wants to get MAPD. Will he get a penalty? Okay. Daniel, can you come off your mute and talk to me for a minute?
Yes, sir.
Okay, so you're 70-year-old. What's their monthly benefit that comes from Medicare? What's their check?
Monthly benefit? I have no idea. I'm not sure. You know why? He signed up um, the initial discovery and Spark, but he does not know his Medicare number. He hasn't
That's okay.
he hasn't been to the doctor for a long time. He said, no, you know. So I told him to go to Social Security and get your Medicare number. But he said he never, you know, he want to get an MAPD, but he does not have Medicare Part B.
Okay. So here's where this will probably fall out, is it depends on what his monthly income is, right? So whatever, if he doesn't work now, whatever his Medicare retirement check plus whatever, if he has like a IRA that's kicked in, or whatever his monthly income is, if it's higher than a certain dollar amount, then he's going to get hit for that Part B penalty.
Okay.
Also going to get hit for his Part D penalty.
Okay.
So he's probably not going to be very happy. But if his income is under a certain amount, then they will wipe out those penalties. So a big question that I would have for that individual is, I need to know what your total monthly income is. And then I would compare that against the Medicaid and LIS chart. LIS alone will wipe out the Part D penalty.
I'm listening to my business thing. I was just
Sorry, Jessica, I had to mute you. So we would look at, does he qualify for LIS, right?
Mm-hmm.
And then does he qualify for Medicaid, right? What are you in California?
California, yeah. Yeah, I just
Okay.
spoke to him last week, and he said that he never go to the doctor.
Okay.
I guess in 1 year he only went one for a visit. That's it, and he never pay anything. But he got Part A, but no Part B.
Well, if he didn't pay, I'm guessing he probably has Medi-Cal, right?
No, he
Um,
doesn't have.
well, I'm curious how he would go to a doctor and not have a payment. No doctor works for free.
Yeah, yeah.
Right? Unless it's one of the church-based or faith-based organizations that do free exams and stuff like that. But I'd be curious to find out where he went. But the answer lies in what his income is.
Okay.
Whether he's going to qualify for Medi-Cal or LIS. And really how it will break down is LIS will take care of the Part D penalty, and Medi-Cal, even at the just the basic level, would take care of the Part B penalty.
Okay.
Okay. Connie,
Okay.
that would apply for you as well. Except instead of Medi-Cal, it would be Medicaid for Florida.
Okay. All right. Thank you.
You're welcome. Okay. Other questions about, actually, Gabe, are you on?
Hey, Carl, I've got a quick question. Are there any other states that their Medicaid systems have what they call a spend down or a monthly deductible, or is Michigan the only one?
Medicaid's funny.
Very.
We're gonna find that out more when we get into next year, because we're gonna break into the Affordable Care Act plans as well. But Medicaid varies state by state. Now, what I've done, you guys can see all the different downloads, correct? Who was that? Adam, was that you that was asking that question?
Yeah.
Okay.
Yeah. Just something specific to Michigan. Indiana doesn't have it. I'm in Indiana quite a bit, but there's been some issues. The reason why I'm bringing it up is there have been issues, and I talked to my inside guy at Humana. Well, you remember Joe.
Yeah.
And apparently the ones that have this partial spend down, there's that monthly deductible, and that monthly deductible is however far over the limit, their income is every month, is what they would be responsible for before the Medicaid actually kicks in. So when I'm going to sign them up for the plan, even though they're Medicaid eligible, they're being denied because they're not eligible until the Medicaid gets activated once the spend down or the deductible has been paid first. So only United Healthcare and Humana are the only two that have a product that will cover this. And even at that, Joe said that Humana's product is not, I don't know, they're fighting with the state of Michigan right now. So literally United Healthcare is the only one that can supply a product in this state for those that are on partial Medicaid. So I just wasn't sure if this was a question for anybody else, or if anybody else had come across this, but around here it's an issue.
Gotcha. Well, no. What you're finding is people who are just above the actual. So we talked about these right here. You guys can see what I'm looking at right now, right? The Medicare Savings Program, all this stuff. Or can you not see this page?
We see it.
Okay. So these are your normal Medicare and Medicaid programs. QMB, SLMB, QI1, and then QDWI, which we don't really worry about. Now, there should be somewhere in this page that talks about, which it doesn't, medically needy, which is also, it falls underneath the Medicare or Medicaid program, but so what happens with people that like that, and that's what it's called in Florida. I'm not sure what it's called in Michigan. Again, every state calls it something different. But somebody who doesn't qualify for one of these plans, right? They're not a partial, they're not even a QI1, they don't even have their Part B premium paid for. They may be what's called medically needy. So let me give you a history on that so you understand how it works and why it works the way it does. There was a time where Medicaid didn't really get involved with Medicare. And so people couldn't afford the copays and stuff on Medicare Advantage or Medicare Supplement, which were more popular at that time. And so what they would do is they would say, okay, well, Medicaid's got this program called medically needy. So if I go to the ER and I drum up a bill that exceeds my monthly income, then Medicaid will come in and pay. And that's kind of what you're talking about right now, right, Adam?
Yeah, well, yeah, basically,
It's a
yeah,
month to
sort of.
month. Yeah.
Anything above the, I think the poverty level, whatever. It's not just their income; it's past the. Well, yeah, okay. Basically, what you said is right. Yeah.
Yeah. It's a formula based off of their income. Basically, it's close to or exceeding their income in bills for the month. Then once that happens, then Medicaid will step in and activate for that month, but only for that month. This is why you can't put those people on dual plans, because their Medicaid will be on and then it'll be off, and then it'll be on and then it'll be off. So those are medically needy people. They're not true Medicaid people. Now, they probably have been issued a Medicaid number, but when you go through the check, right, and it doesn't give you like a QMB or SLMB or a QI1, then you know that they're not a true Medicaid person, right? And if you're dealing primarily with one company, you can always call that company and have them look up their Medicaid status, and they might tell you, oh, they're only medically needy. And then you know that they're not a true Medicaid person. They were Medicaid for a month because they had a set of bills that exceeded their income, but um, it doesn't happen every month, and their income doesn't qualify them for any of these programs here. Does that make sense?
Yep. Totally.
Okay. All
So.
right. So those are hard people to work with because they're just broke enough to not qualify for the programs that would help them the most, and they don't make enough to really go into like a PPO for sure. So you have to be very sensitive with those kind of clients because you want to find the best thing that's going to not interrupt their health care, but really does give them the most amount of benefits. So yes, Medicaid looks at assets. There is actually a whole training that I have done on Medicaid, so we're not going to jump too deep into that. But in each state, which I pulled this right off of Legacy Benefit Alliance. This is specific to Michigan. You can see what it takes to be in any of those classes, right? If I back up to where I was, all the states that offer that are inside of our website. So if you have questions about what is covered in your state, for example, Zoe or maybe Bet, who is actually probably on Zoe's login, you could just download the Florida programs that has all the qualifiers or disqualifiers for Medicaid inside of that form. Let me go back up to Ronnie here. So iSNP is a very unique product. And I'm going to start out by saying that none of us, including myself, are eligible to sell iSNPs. Now, an iSNP is an institutional special needs plan. Really, the carriers themselves are the ones that will they have specific teams that do iSNPs. But none of us will have the opportunity to sell an iSNP. So even though they're eligible for an iSNP, Ronnie, you may be able to look at another product that fits them well. But an iSNP is normally for somebody who's in long-term care or that is going to be in long-term care. And so it's an institutional special needs plan built for institutional care.
Thank you, Carl.
Absolutely. Okay. All right, so I'm going to stop recording because I think we have gone all the way through what we were talking about with med subs.